Hi everyone, thanks for joining us today. You may know me, I'm Ben Tran, I'm a medical oncologist based at Peter MacCallum Cancer Centre in Melbourne, Australia. And I'm really happy to be joined today by a friend of ANZUP and a friend of Australia, global expert in testicular cancer and prostate cancer, Professor Silke Gillessen from the Institute of Oncology in Bellinzona in Switzerland. Silke, welcome today. It's great to have you here.
Hi, Ben. Nice to be in Australia.
I know. I wish you could come around and we can hang out in the warm weather as you're getting colder in Switzerland.
That's true. But no snow yet. That's for sure.
And no travel for a while, I imagine, as COVID comes into its second and third waves all around the world, unfortunately. So Silke, it's great today to have you so we can talk about a couple of things. And today I wanted to bring up testicular cancer, which I don't think gets enough airtime. And, you know, you and I both love treating testicular cancer and helping these young men get cured and live long, normal, healthy lives. And then we'll hopefully move on to something a little bit about prostate cancer, some of the updates there. But I guess the biggest update in testicular cancer recently has been the data presented by yourself and Jorg regarding the update to IGCCG. And I know that arises from the G3 or the Global Germ Cell Group. So I thought, I able to give a bit of overview about the G3, how it started and what it involves and how people get involved. And then perhaps we'll move into some of the updates to the IGCCG.
Yes, so the G3, to be honest, as I thought it, is actually really founded by Jörg Bayer. And I think it's actually an interesting concept because all before COVID, he already choose to this group to be so mainly virtual, right? It doesn't have any administrative stuff or whatever. It's really all done by him on a computer, and I think it's really interesting. And we had all these yearly meetings to meet each other, but people could bring in ideas for retrospective studies, but also for prospective studies. If I remember right, even Tiger was in a way kind of born there, you know, like the salvage chemotherapy second line trial. So I guess it's really like a group of friends and people who are very interested in testicular cancer. As you know, there is not much money into testicular cancer because we can save so many of them with simple, cheap chemotherapy.
I think that was the G3 is my favorite part of ASCO, but as you know, Jorg's not so keen on being in America, perhaps during recent years. But I'm looking forward to having more G3 meetings, perhaps next year or the year after, if we're allowed to travel. But
yeah, so it's already one planned, but there will be a virtual one very soon. He's going to send out the newsletter very soon.
Oh, that's
exciting. So there will be one, and the next one will be virtual. But then hopefully, you know, the other ones, we all hope it's going to happen again. The real face-to-face ones.
And ANZUP was very lucky enough to be involved in the update to the IGCCG. Can you describe a little bit about why we needed to update these prognostic risk criteria and what's come out of it?
Yeah, as you know, so the IGCCG, the original one was published in 1997 already. I mean, it's a fantastic prognostic score. I think we all really use it for deciding for treatment. I guess everyone does. And we just thought, you know, it's quite some time. A lot has changed, right? So first of all, in the original classification, there were also patients included who didn't have chemotherapy that we would consider standard nowadays with cisplatin etoposide as a backbone. But then also we have, I think, really made a lot of progresses in diagnosis, in salvage therapies, in post-chemosurgery. I think we do more centralization. So I guess that's probably also an important point, you know, to really say, okay, these people, these men, we treat in specialized centers. So we thought, okay, two goals. First goal is really to update the survival estimates from the original. So what has changed? What has improved? And the second one was really to see, because we all know there is some heterogeneity in the groups, can we find risk factors that would explain that? So that was actually the two goals of the IGCCG update.
So you first presented the non-seminoma data and then the seminoma data. Perhaps we'll
Right.
start with the seminoma data because it's a little bit simpler to explain, and then we can move on to the non-seminoma data. Can you describe the updates, what we found in regards to survival in metastatic seminoma, and then also what kind of new changes in the prognostic criteria and what other factors you discovered?
Yeah. So as a bit expected, right? So we saw that the PFS and the OS was improved in that modern series that we had. I think the important point is also that, if I remember correctly, in the original classification were about 600 patients with seminoma only, whereas now we have had 2,500. So that's a rare disease. We know that metastatic seminoma is not that, we don't see these patients that often. So I think it's a considerable number of patients that we have here now. And we have seen, again, these improved outcomes. The one other thing that we have seen is that if you look in the good prognosis, the original good prognosis, intermediate, as you know well, right? Intermediate prognosis in seminoma is actually only the presence of non-pulmonary, so extrapulmonary visceral metastasis. Nothing else in the original classification is making you an intermediate risk. And we found now in that big group of good risk patients that probably an elevation of LDH above 2.5 gives you a subgroup that has a worse prognosis.
So Silke, that's really interesting about LDH kind of 2.5 times upper limit of normal, kind of increasing or reducing the kind of prognosis of patients who are thought to be good risk. But what should we do with that information? Do you think we should be giving those patients more chemotherapy? I'm reluctant to do that.
Yeah, no, I think you're absolutely right, because the update was really done in a retrospective cohort, not with like the aim of changing management. So like also with the original one, we now have to do the trials to see if we can dose de-escalate or do have to do dose escalation, right? So I think no, for me, I have also to say I would be very careful to advise any kind of escalation or de-escalation of treatment in these patients.
Great. And the non-seminoma data, a little bit more complicated about the findings from the non-seminoma data. Can you talk us through that?
Yeah. So again, I mean, it was a lot of patients, 12,000 patients. Some of them were not eligible, but we had still something like 10,000 patients where we had all the data that we needed. And also there, I think really interesting in the good and the intermediate prognosis group, the progression-free survival was a bit better, but not statistically significant. Whereas in the overall survival was really significantly improved in all three groups. And then logically in the poor prognosis group, also the PFS was improved. So I guess what that is telling us that we have really made a lot of progress in salvage treatments. I mean, in the end, you don't know why we have that change. As we said, I mean, there can be like a lot of factors, but I think the good news is it has improved. And I guess that is really good news for all the patients. Here, as you said, it was a bit more complicated to look into the risk factors, but interestingly, and we have submitted the manuscript a week ago, so cross your fingers, as you know, because you were part of it. Let's see what's happening. That probably presence of lung metastasis and also age could be additional prognostic factors. And we also built a very nice calculator, I think, and let's see what's happening and if that's going to help people. I really hope that this is going to help other physicians, oncologists, and also the patients to have a more granular prognosis than we had just with the three prognosis groups.
Now, has the calculator gone live yet, Silke? Or if not, do you know when it's going to go live?
So we have one that's already working, but this is on a website that we don't want to use. So in the end, it's really planned to have it ready for publication on the EOTC website, because as you know, the statistics was done by Nicolas Sauvé and Laurence Colette from EOTC headquarters. So I think that would be a good way to have it really like for everyone available and also maintained well.
Now it's going to be it's great to have that resource for clinicians and patients, as you say.
Yeah, and I think, you know, what is really nice, and I want to mention that because it's Australian, Movember has helped us really funding the whole project, because we had to find funding, and as you know, as we discussed also, for testicular cancer is not that easy, but Movember was nice enough to help us to fund the statistical fellow. And then we will also be in contact to discuss a bit if they can then help us to even develop an app on the iPhone or on other smartphone. So I think that will be very nice.
And that's a perfect segue, because it is November, and I've been trying to grow a mustache for about 5 years here, but it's getting there.
Okay, not much effect right now, to be honest, but that's fine.
We might just segue now to prostate cancer, and you know, prostate cancer has been one of these cancers which is you could consider it's fallen behind a little bit when it comes to precision oncology or kind of molecularly matched treatments. In some respects, you can say prostate cancer was the original kind of personalized treatment with, you know, targeting the androgen receptor, which was the clear oncogenic driver. But in modern times, whilst other cancers like lung cancer, we found mutations and drugs that target these activating mutations, prostate cancer has been a little bit behind, but the profound data suggested that we now have a target that can be, for which we have a drug. Can you describe a little bit about profound, what it showed, and then we can perhaps talk about how it might change our practice?
Yes. So first of all, I think it's interesting what you're saying, because it's actually right that probably the hormone receptors were actually the first personalized treatment, except that in prostate cancer we never measured them. We just gave everyone ADT, right?
That's true.
So,
yeah, which is assumed.
we are different from the breast cancer, like our colleagues, you know, who really measuring estrogen receptor and progesterone receptor before saying someone is hormone sensitive or not. So yeah, it's interesting actually. You're right. The profound trend, yeah, obviously, I think, you know, Johan de Bono has done really fantastic work, like really looking for these molecular subgroups. And I mean, you know, the data well, right? They have been presented at ESMO 2019 first with the primary endpoint, radiographic progression-free survival. So there were, I mean, for the people who don't know the trial so well, so patients with metastatic CRPC were randomized to receive olaparib or control, and the control was ABI or ENSA, and I think we can discuss about that. So it was only patients who had a alteration in at least one DNA repair gene, and there was two cohorts. Cohort A was BRCA1, 2, and ATM, and cohort B was all the other DNA repair defects. I think one interesting point is that obviously we couldn't, or they couldn't get really the tissue sequenced of all patients, right? So it seems that about 30% of the patients, it's difficult, even if you know, to get the tissue and to get tissue that's good enough to be sequenced. And I think that's something to keep in mind. And the other point that I think is also really important is, so for me, the control group, I don't know what you're thinking about it, so that treatment wasn't probably really standard of care. So I mean, in that, it was all mCRPC patients, but 20% of the patients had already received ABI plus enzalutamide. And then you give, like in the control group, again, ABI or ENSA. I think we all know that even one after the other doesn't really work well, let alone if someone had already the two. And the other thing was that about 35% of the patients didn't have had any chemo, not docetaxel, not cabazitaxel. Even that we know now that cabazitaxel has an effect after one novel endocrine agent and after docetaxel, but to be fair, that wasn't known at when Profound was designed, but at least also then it was already kind of licensed, right, approved.
Yeah.
So I think that the standard treatment for me was a bit probably non-equipoise. But the good thing of the trial, I think is really nice is that crossover was allowed. So I guess in the end, really a lot of patients, I think 60%, 66% could do the crossover, what was really nice. And so what you know is that so there was a benefit in radiographic progression-free survival for both groups. So specifically for cohort A with BRCA1, 2, and ATM mutations. But the overall survival was improved in cohort A. So again, BRCA1, 2, and ATM. From the subgroup analysis, it looks like it's specifically the BRCA mutated patients who have the benefit, but the numbers of ATM are really small. So I just heard that EMA has approved the drug for BRCA1 and 2. I don't know how it is approved in Australia. FDA has approved it through, I guess, all the DNA repair defects. So as always, FDA is a bit more generous with new treatments, with the approval of new treatments.
So it's going to be a little bit of a shift in thinking for clinicians treating prostate cancer. We now have got to start thinking about testing patients for these mutations. When do you think we should be testing patients? Do you think it's, during when they're first starting hormonal therapy or in early castration resistance? Do you have a view on that?
In the NCCN guidelines is actually like the idea is to test everyone, like that is for germline, I have to say, with locally advanced and for metastatic prostate cancer. To say here in Switzerland, for the germline, again, we can do that in metastatic patients. We are not doing it yet for locally advanced. For the somatic mutations, and that was done for the Profound, we try to do it also early, but I have to say in reality, we're doing it normally in metastatic castration-resistant patients when they start their first novel endocrine agent or after they have had a progression after it. So after a novel endocrine agent, because a lot of patients don't want chemo, right? So you have with the Profound trial, at least an option to give them maybe something else. And it's not approved yet in Switzerland, but you can write to the insurance company, and if you show good data, they sometimes say yes.
Yeah, so you'd be comfortable using it before docetaxel in those who've had Abi or Enza as kind of the first treatment for castration resistance, and given about a third of the patients hadn't had docetaxel?
No, I wouldn't say that. I would just say that a lot of my patients don't want chemo.
Yeah.
So, there are a few that are not fit for chemo.
Yeah, for sure.
But there are many more that would just do everything to not get chemotherapy. And I guess in these patients, the data is not really good, but as we discussed, like 30% of them, so in the trial, 30% didn't have any chemo. So I mean, I'm not into subgroup analysis, but maybe I think we can't say too much if that group also profits or not. But from the mechanism of action, it wouldn't make, I think, a lot of, for me, wouldn't be very logic if it wouldn't work. But in the end, you're right, we don't have good data to really back it up. But if a patient tells me, I'm not going to do chemo, whatever you want, and you don't have any other option, I guess you could do the profiling and see if he would at least fit into the categories of that were in the PROFOUND trial or has a BRCA or 1 or 2 mutation.
Great. I think it's been a great discussion, Silke. Thanks for joining us to talk a bit about testicular cancer and the PROFOUND data. I think we might wrap it up there. So thanks for joining me, and everyone, thanks for listening in, and we'll see you sometime soon.